Hello, everyone. Welcome to the Your Mark on the World show. I'm your host, Devin Thorpe, and today's show is being produced for Forbes, where I'm a contributor covering social entrepreneurship and impact investing. Today's guests are remarkable gentlemen who have been involved in increasing and improving access to health care. They are Steve Weingarten, CEO of the CDFI Vital Healthcare Capital, and we also have with us Bob Master, who is the CEO of Commonwealth Care Alliance. Gentlemen, thank you very much for joining me.
It's a pleasure. Hello, Devin.
Same here. An unusual experience.
Hey, Steve, I wonder if you would start us off by telling us a little bit about how you came to make this $10 million investment that you've recently made in CCA.
Sure. Thanks, Devin, and hi, Bob. Vital Healthcare Capital is a new nonprofit lender seeking to invest in innovative healthcare delivery to advance the right models of care for vulnerable populations. Part of our inspiration, frankly, was conversations I had with Bob Master, my co-participant here today, several years ago. And so CCA is an amazing organization. Bob will describe what they do better than I, but we understood as we were looking around the landscape that healthcare reform was going to be an enormous challenge, and for community-based nonprofit organizations, access to the capital needed to scale up great models of care was going to be a big challenge. So we've been building a new organization. We have support from the Robert Wood Johnson Foundation, and in partnership with them, we're able to make our first transaction earlier this year and have provided a $10 million loan to CCA, Commonwealth Care Alliance, to help them scale up their really impressive model of care.
Well, Bob, why don't you tell us just a little bit about CCA and your unique care model?
Well, happy to. Many of us have been involved in the care of people that are now that are representative in the dual eligible demonstrations for. We've been involved for years and decades clinically, and the model essentially says that if you are a frail elder with long-term support needs, or a younger individual with a variety of disabilities, anything from serious mental illness, physical disabilities, developmental disabilities, or just concurrent multiple chronic illnesses, the organization of medical care as it is today, it really is not an effective approach. And as a consequence, there are just too many missed opportunities to intervene on the complications of chronic illnesses or disabilities. And so this is the intersect between poor quality and high cost, because what that results in is a situation where there are very high hospitalization rates. 95% are through the emergency room for the missed opportunities to effectively manage chronic illnesses and prevent the complications or reduce the complications. And of course, for seniors particularly, it's these recurrent hospitalizations which promote the decline in health, and then the gateway to long-term care placements and loss of independence and more costs. And it's really been our view and the experience of many others that really what is needed is a care delivery transformation that starts with primary care, a much greater investment in it. Generally around the country today, about 4% of a medical spend goes to primary care, and we think it needs to be closer to 12%, 10 to 12%. And the models have to change from a physician-centered or office-centered model to an interdisciplinary team, and a far greater elasticity with respect to intervening on complications in a rapid, a short period of time than exists today in the American healthcare system, and an ability to move the provision of primary care into the worlds of where people live, whether it's in a person's home or whether it's a group home, etc., or a facility. That is really what is needed. So when you do that, you are more effective with this investment in intervening on the drivers of costs and of of healthcare decline, and our model is predicated around the state on that. And so we've been involved really in the since the first demonstration that informed the current demonstration in the care of people with dual eligibles. And the first demonstration really in Massachusetts was restricted to seniors. We cared for equivalents of younger dual eligibles with similar and much smaller Medicaid contracts for people that were indistinguishable from the younger dual eligible population. But we are a nonprofit organization, and when we embarked on OneCare, and we're relatively undercapitalized given the challenge of OneCare as a nonprofit. Our access to capital is constrained compared to others, and we needed both to make investments in our clinical infrastructure and expansion, investments in our management, operational, and IT infrastructure, and to scale what we had and where we a year and a half ago, and where we were a year and a half ago was caring for about 5,000 seniors, managing about $250 million of Medicare and Medicaid premium, which says something about how a year says something about how medically complex and expensive these populations were. We had a network of about 45 primary care practices, and we had funded about 100 teams of nurses, nurse practitioners, social workers, behavioral health clinicians that were the interdisciplinary component of these primary care practices.
Right.
And we were very, very successful, but we were going to need to triple in size, and thus we needed both to make our own investments, but we also needed funds to meet the regulatory reserve requirements. Being fully at risk, we needed, and there were a variety of requirements, one of which was having sufficient working capital and cash that could be satisfied through low-interest loans. And
I see.
And that really was where VCAP came in, because it was this obviously we would have a break on our ability to expand if we did not get the sufficient capital into our organization.
That's great, Bob. Thank you. Now, Steve, I wonder if you would tell us a little bit more about the partnership with the Robert Wood Johnson Foundation.
So Robert Wood Johnson Foundation actually has followed and supported CCA's development over the years, and I think was highly interested in figuring out if they could be of help in helping to scale this excellent model of care. So we were initially retained by Robert Wood Johnson to look at CCA's financing needs and diligence the opportunity. Robert Wood Johnson had been an early funder of ours and was interested in supporting our development as a nonprofit lending platform to help advance quality health care and the safety net. And so we examined the CCA opportunity for them, and then became the intermediary vehicle for Robert Wood Johnson to fund the resources for the loan. So Robert Wood Johnson is the financial sponsor and a backer of ours and a partner in the transaction.
Great. What is the nature of the transaction? Is the $10 million loan the only piece in this transaction, or was there an equity piece or a senior debt piece or other parts to this puzzle, or is it just a $10 million low interest rate loan?
It's a $10 million loan. At some point we may, with CCA, support a co-lender alongside to further add to CCA's capitalization, but the initial deal was a $10 million, fairly straight-looking loan.
Fantastic. What other kinds of things are you looking to do?
So we are right now putting in place the next tier of capitalization and expect to make our next set of loans in the first quarter of 2015. Our mission really is to support the development of good healthcare jobs and quality healthcare for low-income communities and vulnerable populations. We will be looking across the continuum of care at opportunities to advance models of care that sort of fill in the footsteps of CCA, high quality for the hardest to serve.
Tell us a little bit about your operating model at VCAP. I want to understand what it means to be a CDFI and how you are aggregating, managing, distributing capital.
Yeah, so we're a nonprofit intermediary financial institution, and we pool a capital that includes grants and contributions, low interest loans to us, and more market rate loans from banks and others that need to meet their Community Reinvestment Act obligations and are committed to impact investing. And so we're then focused on healthcare, are able to look at the complex nature of change as healthcare goes through this period of restructuring and find credit-worthy investments we can make that have high impact on communities in need.
So, Bob, I wonder if we could come back to you for just a minute, and I wonder if you would just give us a quick summary of the history of CCA so we understand where you came from a little bit.
Okay. Well, some of us go back more decades than we probably would care to admit to, but the origins of CCA really go back well to into the 1970s. And in Massachusetts, we had a very progressive community health center movement, and there were physicians and nurse practitioners that started in that movement, caring for people, low-income individuals with complex needs. And that really began the I think the consciousness began there, that the existing structures of ambulatory care and fee-for-service care just didn't work for the populations that I mentioned. And those of us who are, I'm a primary care physician, those of us who were doing this work just said, if we're going to do this, we need different approaches to financing and different approaches to care. And that began essentially a career-long quest to try to demonstrate and evaluate what they were for different populations that we were caring for. And now you need to have an accountable entity, clinical entity, to care for these populations. You have to move your financing from fee-for-service piecemeal work to global payments, where there is a opportunity for population-based management and the opportunity for the enhanced analytics and data that an accountable entity with a global payment financing can have. And then you needed to think about clinical redesign. And over many years on small scales, we were able to develop these redesigns in collaboration with varying academic institutions, our state Medicaid program, and foundations. And Steve is right. Robert Wood Johnson funded over 30 years many of these demonstrations. And essentially the principles that I talked about in terms of investment in primary care and one iteration or another, interdisciplinary teams were developed and evaluated for a variety of low-income populations, frail elders who were homebound, individuals with very involved physical disabilities that were increasingly living independently. In Massachusetts, we were the first state to have a personal care assistant benefit going back to the 70s, so we had a lot of such individuals coming here. Then later on, HIV/AIDS, and then people with serious mental illness. Wherever you went, you had to think about resizing and reimagining and redesigning what that primary care model looked like. In my own personal quest, life's odyssey, I went into the Dukakis administration in the leadership role in our Medicaid program in the mid to late 1980s, and that's really where we saw the very same people we were trying to develop, the very same people for which we were trying to develop a primary care model, were the cost drivers of our Medicaid and our state Medicaid program, and the idea of then imagining issues like risk-adjusted premiums that come to clinical entities started work in the 90s, that actually started to move, along with certainly many others, move the whole experience of risk adjustment along, that now is embedded, so completely in our federal Medicare program and many state Medicaid programs. And the Commonwealth Care Alliance is really the latest in the iteration of this work. The last 10 years have been at a scale that was much higher than any of the population-based demonstrations that I described earlier. And of course, what is happening today, where we've gone in a year and a half from 5,000 to 6,000 enrollees and $250 million now to 16,000 enrollees in a year and a half, up to annualized about $600 million of premium, really is the ultimate scale test for us.
Wow, that's great.
That's kind of our history in a couple of minutes.
Yeah. Well, Bob and Steve, I congratulate you both for the successful transaction and for the innovative approaches you're taking to healthcare in the United States. I'm excited about what you're doing, and listen, hope that you'll be very successful now and in the future. Thank you very much for making time for us today. It was great to hear your story.
Thanks so much, Devin.
Thanks.
All righty. Now, Steve, I wonder if you would take just a moment and tell people how they could connect with you if they're interested in accessing capital through VCAP.
So please visit us at our website, vitalcap.org, vitalcap.org. We're, again, a new nonprofit financial intermediary, and we are looking to now make our next set of investments in great healthcare providers serving hard-to-serve populations.
Great. And Bob, how do people find you?
Well, we're also online. It's www.commonwealthcarealliance.org, and that's certainly one way. And go on to our website, and then and through that there's a wealth of information about us and contact information as well.
Thank you again, gentlemen. I really appreciate your time today.
Thank you.
All right. Let's do some good.